Okay. Good morning. My name is Professor Patavro from Berlin, Germany, and we will moderate the session together with Andrew Civitello, and we have a panelist, and I would like to ask you to introduce yourself very short.
Good morning, Dr. Tin Pham from Cardiac Surgery at Northwestern in Chicago.
My name's Michelle Ferry. I'm a nurse practitioner in the cardiac ICU and with the ECMO and cardiogenic shock programs at Inova Fairfax Hospital in Northern Virginia.
Morning, I'm Steve Hollenberg. I do critical care and cardiology at Emory in Atlanta.
Hi, Joyce Wald. I'm medical director of shock team at Penn in Philly.
Esther Vorovich, medical director of shock team. I'm a heart failure doc at Northwestern.
I'm Rahat Hussain. I'm associate professor at UT Houston. I'm the medical director of the lung transplant program and an ECMO specialist. Thank you.
And the first speaker is Sophia Airhart, and she will speak about managing pulmonary hypertension with RV failure. It's a very challenging topic because it's very difficult to do it.
Thank you. Thank you. Good morning, everyone. All right, delighted to be here with friends and colleagues and thrilled to see the RV get its due recognition. All right, here are my disclosures. While I know this is a shock conference, this is PAH, so I also want to dive into some pre-shock strategies, and I will also do my utmost to condense this vast topic in 7 minutes. So let's start by defining the disease. As you may know, pre-capillary pulmonary arterial hypertension is now defined, as is all pulmonary hypertension, as a mean PA pressure over 20 to try and diagnose and treat the disease sooner. And precapillary is defined as a PVR over 2, in addition to a wedge pressure less than or equal to 15. So however you slice it, elevated estimated RVSP by echo, shown in the top figure, with 1-year mortality in blue and 5-year mortality in red, as well as invasive hemodynamics with increased PVR and mean PA pressure, is associated with increased mortality due to their role in right heart failure. So PAH is marked by progressive elevations in PVR, as shown in the top photos, with progressive intimal hypertrophy and endothelial cell obliteration. The RV's response to increased afterload, which sometimes can be unpredictable, is crucial for determining symptoms and survival. And so that's what I want to focus on today. Here, you'll also see PH final phase, which shows increased PVR and RA pressure from decreased forward flow, and a fall in cardiac output, and a decline in PA pressures when the cardiac output falls, and the RV can't generate adequate systolic force. So just as a reminder, the severity of PA pressure increase does not define pulmonary hypertension and decreases in end stage. So this shows a compensated PAH patient. You see normal RA pressure, wedge less than 15, high PVR, and this RV still has reserve. Output's preserved, and it's not uncoupled from the pulmonary artery. So what would you do for this patient? What's the next step? Risk assessment is key, and you want to start therapy. Risk assessment is based on hemodynamics and RV function measures. A patient's risk can vary widely, from low at less than 5% at 1 year to high at greater than 20%, and this guides therapeutic decisions. And if you look at the REVEAL score, it's more of an ordinal scale, and so you see more incremental increases versus REVEAL is the 3 strata. So you do your risk assessment, and you decide initial therapy. However, despite your best efforts, this patient continues to decline and become symptomatic. So you repeat a right heart cath. Here you see a drop in cardiac output, a rise in PVR, and your RA pressure is going up dramatically, which in and of itself is a poor prognostic marker, and the unfavorable RA to wedge ratio is also predictive of poor survival. You may also see a slight rise in wedge pressure due to RV septal bowing into the LV, something that can be called reverse Bernheim effect. So you go back to your risk assessment. Clearly this patient is higher risk. You want to diurese, escalate therapy, and consider transplant referral. In this case, it's important to remember that parenteral prostacyclin is the first choice for high-risk patients, as it's the only therapy shown to improve survival. But despite your best efforts, as this is a progressive and curable disease, later on, as this patient's waiting for transplant, they really crump. They're in fluid shock, their lactate is going up, their kidneys are going down, and their PA pressures are declining due to a decrease in cardiac output. And you actually see their wedge pressure go down a little bit because now their LV is underfilling from lack of forward flow. So what do we do for this patient? These are all clinical considerations for the failing RV, and we'll briefly review the highlights. It's important to remember that RV perfusion changes under stress more than the LV. The RV is a thin-walled, morphologically and embryologically distinct ventricle from the LV. When it's healthy, it ejects into a low-pressure, low-resistance, high-capacitance system, and you get perfusion during systole and diastole. However, in the case of PAH, when you have high afterload, RV wall tension increases, and you get coronary blood flow only during diastole, which further diminishes RV performance. It goes without saying that it's important to identify and correct triggers for acute right heart failure. And this is a list specific to PAH of common triggers for right heart failure, including supraventricular tachycardias, infection. With high right atrial pressure, you can get bowel translocation, and patients are at risk of bacteremia from indwelling lines or from sub-Q infections if they're on long-term parenteral therapy. Hypoxemia clearly worsens pulmonary hypertension, and with increased RA pressure, you can sometimes get opening of a PFO. Surgery, anesthesia, and routine things other people get, like infection and PEs, anemia, non-adherence, can all worsen this state. So after determining the etiology and chronicity of right heart failure, it's important to have a SWAN to guide treatment, and I think of it in 3 buckets. Just like the LV, preload, inotropic support, and afterload. Preload is really key, and as you heard from our team yesterday, we don't want to volume overload the RV. Clearly that leads to worse function, and decreasing the RV EDP improves ventricular interdependence. If your LV is underfilling, consider inotropes before diuresis. So what about inotropes? Well, consider early inotropes if these markers are present. And to point out, there's no consensus or evidence-based recommendations for the choice of pressor inotropes in the treatment of decompensated right heart failure. But I agree with the discussion yesterday, 100% stay away from phenylephrine. If you're hypotensive, you may consider dobutamine or epinephrine. And if you have blood pressure room, you could consider a vasodilator like milrinone. Avoid hypotension at all costs. You want to keep your SVR higher than your PVR. And of course, maintain oxygen saturation and your oxygen carrying capacity. In this patient population, it's important to rapidly uptitrate prostacyclins and consider the addition of nitric oxide. Avoid intubation, which can really be catastrophic in this population. And this is a brief summary looking at how you may change management after assessing blood pressure and hypoperfusion. So with regard to mechanical support options, via ECMO is the preferred strategy, but like any other case of ECMO, it's important to ask, what is this a bridge to? And really, there's no role for RVADs due to the risk of pulmonary hemorrhage and the lack of evidence in high PVR states. So thank you for riding along. I look forward to a great discussion.
Thank you very much. Some questions from the panel?
Sophie, how often are you doing lung transplant for these folks versus just getting away with medical therapy, and when do you pull the trigger for lung transplant?
Yeah, thank you. That's a great question. Well, I have practiced at lung transplant centers. I'm currently not a lung transplant at one, so I collaborate with multiple lung transplant centers, and so in my opinion, the earlier the better, because then you have that longitudinal care, so they can establish, get to know the patient can feel comfortable with them, and when they have a more rapid decline, then it's easier to get them there. There is, a very active discussion, because if someone goes to lung transplant too late, they have worse outcomes, of course. But if they go too early, then lung transplants don't last forever. So I think it is patient and center dependent, but I initiate that conversation and that relationship early. Yeah.
Awesome talk. I'm actually going to email you for your slides. But it's a random question in all of this. So as you grow your PH program, you get more and more PH patients. I feel like we're getting inundated with them as our PH program grows. What's the role of, so we have patients that we end up crashing onto ECMO. A lot of times we're meeting them for the first time, figuring out as a bridge for atrial septostomy as a rescue.
Yeah, that's a good question. I have not used that frequently, but I have crashed people on ECMO awake, which is helpful to get to know them. And I mean, frequently on ECMO, I haven't needed atrial septostomy. So yeah, how about in your practice?
So first caveat, I am not a PAH person, but we see a lot of them on ECMO now because our PH program grew so much. The first time it was suggested to us by the PH team, all of us thought they were kind of completely off the wall crazy. We thought they were going to be hypoxic. But then it worked really well. She came in active labor with PAH.
Oh, yeah.
Ended up cannulated in the OR for awake ECMO cannulation in the cardiac OR because she was actively laboring with a lactate of 8. It was wild. But we couldn't get her off ECMO, and she was just getting an IV prostacyclins, and it worked. But it took like 2 weeks to convince the cardiology team that we weren't going to kill her with it. But I was just curious because it made us feel differently about it. But I don't know, it still seems a little...
Yeah, you can actually maybe think of it as the cheap Impella of PAH, right?
Yeah.
I actually was at a conference recently, and in Thailand, they're doing atrial septostomies because they don't have access to Impellas in LV failure too, which is really interesting from that physiologic perspective.
So for lung transplantation in patients with pulmonary arterial hypertension, the ISHLT put out some guidelines about in 2022 or so, and review score of 10 or more on optimum therapy, and if you still have a New York Heart Class 3 or 4, despite your optimum therapy with prostacyclins IV, probably is a good indication at that point in time to refer them. When we see them in the ICU, when they are on inhaled nitric oxide or on ECMO, ECMO has single-handedly been shown to be a bad prognostic marker for 1-year survival in all lung transplant patients. So I would just probably try to refer them early, like what you're doing. I think that's a great idea. And follow the review score to the T, and then refer them at that time.
Yeah, I would say if they're symptomatic despite high-dose triple therapy with prostacyclins and the addition of perhaps a sotatercept as you move them towards the transplant center.
How do you cannulate ECMO? Do you use peripheral femoral approach? Do you use axillary approach? Also question to the panel. What is the optimal approach?
Yeah, so it varies a little bit, but I think the ideal scenario is to be able to cannulate them in a mode that allows them to ambulate. I think that for patients, that's the best outcomes. So we do a variety of things. If they're small enough and it's urgent, we just do a femoral cannulation and we try to ambulate them. And then as soon as we can, we try to convert it to a central cannulation strategy, either through an axillary or sometimes we do an upper hemi, put sew in a graft and tunnel it out.
Same with our center as well. Via ECMO cannulation with femoral access is probably one of the best ways to do it. In the last 2 or 3 years, and COVID has taught us a lot how to ambulate these patients, even though if they have femoral cannulations. So because of our robust ECMO team, I think we are fairly comfortable with fem cannulations.
But they cannot be ambulated or very limited ambulation. So my idea was we do it in Berlin using axillary artery. So to this.
No, so we do ambulate our VA ECMOs, even with fem cannulations.
Thank you.